advice to medical professionals. At DPM, we've always looked after doctors, and that has given us a really good understanding of the medical career pathway so that we can tailor-make our advice to our clients' needs to ensure that they're in the best possible financial position throughout their individual careers. To facilitate this advice, we've actually structured our business so that we have we surround our clients with all of our services. Our advisors actually work in the core services of tax and accounting, finance, insurance, and wealth. We have 3 specialty services of property advocacy, legal, and self-managed superannuation. What I want to run through with you tonight is some things for you to consider from a financial perspective moving into your internship year. Some of you might actually not have earned income before, and it might actually be the first time for a long time. So it's really important that you do get on that best foot, so you put your best foot forward next year. So the first thing you want to do is set up and get advice in relation to salary packaging. Salary packaging is a tax saving that people working in the public health system have at their disposal. It is really critical to actually get advice in relation to salary packaging, as the rules do change from hospital to hospital in relation to what you can salary package and when you can salary package. Essentially, you actually can earn a portion of your income tax-free, and this will increase your fortnightly take-home pay. It actually runs from during the FBT year, so from the 1st of April through to the 31st of March. And there are 2 categories upon which you can salary package. There's category living expenses, so what you can package there is rent, loans, and credit cards, and also other expenses. So that has a cap of $2,650, and you can salary package venue, hire and accommodation, and meal and entertainment. You can also package 1 portable electronic device per FBT year as well. So once you've got your salary packaging set up, it's really important to review your income based on your annual salary of around $65,000 next year, as well as the expenses you expect to incur. Once you've reviewed your cash flow, you can actually set up a budget, and look at if you have a surplus or a deficit. So if you have a surplus, you really need to have a think about what you want to do with that money. So if you want to keep it for savings, training course fees, or a holiday, and if you have a deficit, it's really good to identify that early and correct it so that you are moving in the right direction for your internship year. At DPM, we can assist you with cash flow and budgeting tools as well as software. You can actually use this software to track your income and expenses that go into your tax return. For some of you, it might be the first time you're actually doing a tax return. So we provide advice on what goes in the tax return and also what to keep track of throughout the year. Essentially what a tax return is, it's a reconciliation of your income and expenses, the tax that you've paid compared to the tax that you should have paid. So if you've paid too much tax, you'll probably get a little bit of a refund back. If you haven't paid enough, you'll probably have to pay the ATO some more tax. It's worth noting that there are some income thresholds where if you pass these, you might have to pay additional taxes. For example, if your repayment income in relation to your health debt is over $55,000, you'll have to start paying back your health debt. Furthermore, if you earn over $90,000 and you don't have private health insurance, you may have to pay the Medicare levy surcharge. If we have a look at insurances, at DPM, we actually provide advice on the 3 key personal insurances of life, trauma, and income protection insurance. We believe that you need to get the structure, your benefit, and your waiting periods set up correctly, because this is what your premiums are based on. We really think that income protection insurance is critical in your internship year, because it is when you're starting to first earn an income. And you really need to consider how you'd afford your expenses if you didn't have that income. Essentially what income protection insurance does is it pays you a monthly benefit while you're not working due to either being sick or injured, and it'll actually pay you that benefit up until retirement age if you can't go back to work. So this really gives you peace of mind that if something does happen to you, you're financially stable. At DPM, if you'd like advice in relation to any of this, we actually offer no obligation initial consultation. So come in and sit down with Anthony, Elise and myself and get specific advice for your circumstances around salary packaging, tax, insurance, cash flow and budgeting. Get it all done by the end of the year so you can really enjoy your holidays. So you can book an appointment with us by shooting us an email at grab@bpm.com.au, or you can jump onto our website and fill in an online booking form. Congratulations on making it this far, guys, and the best of luck for the rest of the year. Any questions? Perfect. No worries, thanks guys.
Yeah. Excellent. Now, there's people online, so where do I need to stand?
That's fine.
Right here? Okay. Okay. Do I have to stand right behind it? Because I kind of get lost being my side. Is that okay if I stand here? All right, terrific. Okay, everyone, my name is Michelle McIntyre and I'm from Avant, which is a medical indemnity company. First of all, I'd like to say congratulations on your exams that are about to come and you're going to all pass, which is great news. And welcome to the next phase of your medical career. Today I'm here to talk to you about medical indemnity going forward and what happens sort of in your intern year and beyond. And I also, if we've got time, want to give you a little bit of insight as to what happens with your medical indemnity as your career progresses. With regard to your intern policy, can I just have a hands up of those of you who had your policy with us as students? Beautiful. Can I have a hands up as to who's used the travel insurance policy? Beautiful. Okay, terrific. Okay, now during your intern and your RMO 1 years, the likelihood of you needing a medical indemnity policy for a claim to be made against you by a patient is pretty remote. In fact, extremely remote. The only likelihood of that occurring is if a criminal act has actually been has been performed. However, having said that, there's a lot of other things that are covered under your medical indemnity policy that you may need cover for in your intern and your RMO 1 years. You could be asked to submit a report to the coroner in the event that you are on an ED rotation and a patient died in either your care, whilst you were actually on that or whilst you were actually on that shift. You could be involved in a disciplinary issue with the hospital, or you could have an issue with another doctor in the hospital as well, and in which case you would need to look at us. Or you could actually have a dispute with the hospital, and sadly that does happen on occasion. You might be offered all manner of things, but when it comes to the cold hard reality, some of those things just don't come into fruition, and in which case you need to use us and need to contact us for all of those things, and basically anything that kind of goes wrong in your medical career so that we can guide you and give you the best advice possible. Avant is Australia's largest medical indemnity provider. We have about 53% of all of the doctors insured with us here. And I'm sure, as you already know, we're often referred to as an MDO or a medical defence organisation, but technically we are an insurance company as well. We are a not-for-profit company and we are owned by our doctors. So any profit that we do make, and the good news is that we do make a profit, goes back into the medical industry to support you in functions like this, but right throughout your career. So essentially joining Avant gives you access to our 24/7 medico-legal advice line, and this is to help you out for anything that you think that you might need advice on or some guidance with. The cover that we offer you is obviously for your intern policy. We also include the free travel insurance again, And all you need to do if you're going to use the travel insurance is go onto either our website or contact us on our 1-800 number and just register your trip. So we just need your departure and your return date. It also includes our emergency medicine handbook, which looks like so. This is something that many of our doctors still keep on their hips or closely attached to themselves well into their career, because it's got an incredible amount of information. It's got diagnosis and management plans for just about every illness, injury, etc. So it's a great little resource for you to have. Of course, going back to the travel insurance, of course, that's available for you for all domestic trips and international trips. The maximum duration of any one trip can't extend beyond 6 months, but I can assure you in your intern year, you're not going to get 6 months leave anyway, so we don't need to worry about that. Now, to organise cover with us this evening, all you need to do is fill in the application form, which we've got at our table, and we'll then give you the emergency medicine handbook. We only get a certain number of these emergency medicine handbooks, and once we're out of them, then they're no longer available to you. So my advice would be, if you're going to hold off, you may not necessarily get this book if we've already run out of supply. So come and see Vanessa and myself at the end of this evening. Fill in the application form and we'll get the policy in place for you. Now the policy that you'll be starting this evening will cover you from tonight until the end of December 2018. So you'll have it all sorted until then. I think that's about it. So I think my time's up, isn't it? Yeah, okay. Well, I was going to go on a bit further, but I won't. So thank you anyways, and we'll see you out there a little bit later.
Oh, no one else? All right, so I know a few of you, but I haven't met all of you actually yet. So my name's Jason. I'm an intensive care and emergency injury registrar at the Austin. For what it's worth, before we start going through the presentation tonight, first of all, I'd actually just say about all that stuff I just talked about. It sounds boring as all shit, and it sounds like it's confusing, but I highly recommend, before you start internship, get a group of like 5 of you together, just make some day of it with alcohol and pizza or something, and go through and organise all that stuff, because it helps having all of your tax stuff sorted, all the insurance stuff sorted. It saves you money in the long run. You get a heap of money back from your tax return, so it's definitely worth doing. The only other thing that I thought I'd raise, and given that you guys are here, you guys get to make the decision at least. There were a couple of topics that I think you mostly picked about, things you wanted to talk about, things you're sort of concerned about leading up to internship. I think it was the usual things like met calls and things to chart and medications, antibiotics. Regarding the sort of met calls, resuscitations, that stuff, I can probably help a little bit. Regarding things like whether you want to give someone 5 of Vendone or 10 of Vendone and Panadol, probably not that great a person to ask. Antibiotics, there's a great website if you've ever seen therapeutic guidelines, which tells you exactly what you need to know, right down to the microgram of how much you need to give and when you need to give it, depending on whether you're in renal failure or not. So I guess that was my little blurb to say, if you really want, as a group, a lecture about antibiotics and about analgesia, I'm more than happy to put something together and we'll do it in the last session. But otherwise, I'd probably suggest that sort of stuff that it'll freak you out for the first week that you're on the job. And then by 2 weeks into the job, you'll be like, I'm so fucking sick of writing everything in Nurofen. So if you want it, I'm happy to, and just contact Michael and sort of let him know as a group whether you actually want to do it or whether you'd rather we go through more sort of net call scenarios, all that sort of stuff. So having said all of that, why don't we start with today's talk. So given that I'm a ED ICU sort of person, you're bound to get a talk about arrests and resuscitations. And the thing is that really, I think, for the people that I have as interns and residents and sort of junior registrars, if you can do this stuff well, you will look really good, obviously, right? If you're efficient, if you do your paperwork as an intern, you get the discharges out, all the scripts done, and you're there every morning with your coffee 10 minutes before the registrar, you're a normal intern. If you don't do that, you're bad. If you do it, you're normal. And there's really no way to excel by doing that. The way that I think you excel is in these sort of scenarios. Maybe not specifically when they're dead, because it's a bit hard. But these sort of things, the emergencies. And I think if you're going to actually be involved in acute care medicine, which you all unfortunately will be next year, whether you want to be long-term or not, you're going to have to try and learn your way through these sort of scenarios. So today I sort of want to talk about 4 main things. Being able to master your fears, being able to master the knowledge that you have or don't have, being able to master your decision-making, and the most difficult one, arguably, is being able to master the environment. Now, I do say all this, but I'm not actually really much of an expert, so I'm only, 4 or 5 years ahead of you guys, so I'm still not there myself, so by all means, take everything I say with a grain of salt. But this is at least what I've sort of felt has worked for me, and what I feel works for at least the junior people that we teach. So why don't we start with the first one, the easy one. Let's start with fear. So given that I've been talking to Michael through email, I'm going to get him up here for a sec. Come stand up. So I'm not sure if you guys all know him, he's one of the MD2s, right? Yes. Yeah, good. And most people here are MD4s, is that correct? Cool. So they've all done a bit more than you have. Yeah, a bit more learning. Good. And so I thought while we were here, I might actually give you a bit of a test in front of everybody, just about some medical knowledge.
Love it. Yeah.
All right. And then what we'll do is we'll get one of the MD4s to actually come up here afterwards and see if they can get that stuff right as well.
Cool.
Yeah? Everyone on board? So, before we go through it, how do you feel right now?
Oh, pretty tired.
How does everyone else feel? Anyone worried? Bit scared? I'm going to pick them out to stand up here. It's going to get streamed and put into YouTube, and everyone can watch again and again and again if you make a mistake.
Yeah.
A little bit scared?
Yeah.
Yeah. Now imagine when you do this, but in front of a dead person, the family stand around, and the nurses there that you work with, and your registrar that walks in late and has absolutely no fucking idea because they're a surgical registrar. I know he's an awful board as well. It's really tough. You can sit down, I won't actually test you. So, probably right now, I'd say you're probably getting close to maybe the yellow or red zone of fear. There was this guy called David Grossman. He was a combat pilot back in, I think, the 40s or so, 50s or 60s. He worked with the US Air Force. And essentially in a time where, he's written books. So he's a Marine, I'd say at the back of the Air Force, Marine. And he wrote these books about psychology. He actually went off and he decided he wanted to do a PhD after his time. He wrote these books about how people react in stressful situations, how fear works. And he came up with this system, and he just had these random colors associated with it. And most of the time, we live in the blue zone, which is normal. And he's put heart rate numbers next to them. I don't necessarily think that you have to have a heart rate number associated with it, but it's a general gist of it. Everyone's normal, it's fine, going out your normal day, doing your normal thing. And then you can be put under a little bit of stress, and you get into that yellow zone, where everything's all right, you're a little bit heightened, it's like maybe the first lecture or something, or you're not quite sure what to expect, and you're on edge, but you're probably at about your peak performance mentally. And then you get a little bit more scared because you're under stress, and you go into the red zone. The red zone's where you really start to deteriorate, where your fine motor skills go out the window, your gross motor skills start to probably go out the window as well. And unless you've done a lot of training and a lot of continual repetitious sort of things, you probably can't function much. Then you sort of get into the grey zone, which is where you really start to look like shit, tunnel vision, blurry, start sweating, shaking, tingling, and then the black zone where you shit yourself, literally. All right? And the idea of all of this was to try and understand that throughout these sorts of zones, you'll perform differently. And there's ideal scenarios when you want to be in each zone. If you were a firefighter and you had to break down a door and carry 4 people over your shoulders outside of the thing, you probably wouldn't want to be in the blue zone. You'd probably want to be red zone, where you're full of adrenaline and ready to go and bash in a wall. However, for us, that doesn't really work very well, because we have to use our brains. We have to be able to do fine motor skills, cannulas. We have to be able to assess ECG rhythms. We have to be able to make decisions, give milliliters of medication, and not too much and not too little, otherwise it doesn't work. So we sort of probably have to be more around that yellow zone. Problem is, when I got you up here right now, it's a bit hard to stay in that yellow zone, isn't it? Especially if you don't really know what it is you really want to, what you can do. So there are a few things you can do to prepare for the fact that you will be scared. And I'll tell you right now, you will be scared. Next year, in the first week, in the first month, the first 6 months, you'll come across a scenario that will scare the living shit out of you. And it will happen again, and again, and again. If you don't have a way of coping with it, a way of dealing with it internally and mentally, you'll fail. I don't mean fail internship. I don't even mean necessarily fail in that situation, because it might be fixed by someone else. But you won't really get what you want out of it, and you probably won't end up continuing to do it. So there are a few things that you can go through to try. First of all is training. Sounds simple. And the simple thing of training is you only have to train the simple things, the basics. So what makes an expert really good? What makes like an intensive care consultant the best at resuscitation? Is it the fact that he can crash someone to ECMO when they die? Might be helpful, yeah, sure. But probably not. It's the fact that if he has to do a cannula, if you've ever seen an anaesthetic consultant do a cannula, for any of you who've done anaesthetics rotations, they do it like half asleep, blindfolded, with their left hand into someone else's foot, like not even using a cannula, like they're awesome at it, right? Because they do the basics really, really well. And that's what you need to try to train. So you have to understand about the basics. That will help alleviate the fear. There's also the 130% rule. And this is something that's sort of born out of, I'm going to talk a lot about the military, so I do apologize. Unfortunately, there's a lot of like, we like to believe there's a bit of a crossover between resus care and military to make ourselves feel cool. But yeah, the military come up with this idea of the 130% rule. And the idea is that you train to 130%. You hold yourself to a higher standard when you're in your training scenarios and when you're practicing, so that when you get to the real situation and when you drop, when your performance level drops, because it will, then you fall back to 100%. Sounds ridiculous, sure. They don't understand percentages, they're only military people, right? But the idea is, and you might notice, you've all done sims, I guess, by now, lots of sims. How many of, like, can you honestly sit there and say that you walked out of a sim feeling like you fucked up? Because you probably had it at some point, right? There's something you didn't know that you were like, oh my God, I can't believe I fucking did that, right? So you've done it. But how many times did you actually, honestly, legitimately, with the whole group in the safe environment, talk about it? Anyone? Or does it sort of get washed over a little bit? Is it sort of like, oh, look, I know you didn't pick that the guy's heart rate was 30 for a couple of minutes. And I know they weren't responding, but you did introduce yourself pretty well. That's good. That's good. Right? So the problem is, I think inherently we don't do that very well. We don't really train hard enough. And we don't get many opportunities to train hard enough, is the other way. So when you go next year, you'll be the intern on the ward, and that's it. You're looking after the same people that your medical boss of 40 years is going to be looking after. So it's you or it's them. Same person in front of you, same problems, same non-textbook pathology that's going to hit you in the face. So you've got to get used to it. And I think the way to do that is to train a little bit harder. So hold yourself to a higher standard when you're not actually at work doing it. The next one is stress inoculation training. Has anyone heard of that term before? No. So the idea is that, that you basically stress people out, get them super, super stressed, and then get them to do stuff. And they get good at doing stuff when they're stressed, and then surprise, surprise, they get better at doing stuff in real life when they're stressed. Now, this is sort of the best way to do it. You tie people's arms and legs together, you blindfold them, and you throw them in a pool with a weight on their feet and tell them to get out. It's pretty stressful, right? Can't see, can't move, tired, underwater, holding your breath. Of course, there are people there to try and get a shot when you stop, when you can't breathe. So maybe just resuscitate afterwards, whatever, right? Unfortunately, I don't think APRA really approves of this, so I can't make you guys do this as a way of going through the stress inoculation training. But in essence, there are 3 phases to stress inoculation that you can do with each other, or when you go through simulations, or even up here in the best simulator that you've all got in your head. Right? And the idea of these sort of phases is that you have to, first of all, conceptualize what it is you're going to be doing. Then, unfortunately, you have to get good, so you have to get skills to do what it is you're going to be doing. And then you start the application of the stressing yourself out process. The way that it sort of works, the way that we're starting to try to do with people in our simulation labs when we do it for the registrars at the Austin, is that you basically have to, first of all, work out with everybody where they're at. And people have to be involved. It's not something that you can force, unfortunately, on people. If you don't want to do it, you're not going to be a part of it. But if you want to be involved with it, then you create that sort of mutual bond, that contract, that understanding that over the next few weeks, few sessions, we're going to put you into horrible scenarios. You teach them skills to be able to deal with those horrible scenarios slowly. So for everybody, obviously the horrible scenarios are the arrest scenario, the can't intubate, can't oxygenate scenario, the bleeding trauma patient, all those sorts of things. And you teach them how to, the skills that you'll need to get out of those. And then you do it. And then you put them in a simulation. And not a sim that lasts for 5 minutes where it's just like, oh, the heart rate's high, what do you do? Oh, well, say hi to the patient. Oh yeah, great, that was it. You put him in a sim that goes for like an hour, that sort of actually simulates real life, where shit goes wrong, where people give you the wrong medications in the wrong syringe, where people don't have equipment, where you've actually done everything right and by the textbook and it's not working. You do things like that and it stresses people out. And that's how you get good at it. Now, we talk about, that's a medical specific stress inoculation testing. The great thing about stress though, is if you're good at managing stress, you can actually manage it in different scenarios. So you don't have to, because it's pretty hard to get what we just talked about. You have to have a group of people that are willing to do it, simulations, teaching, it's all really difficult. So in some ways, if you want to do it by yourself, and not necessarily that I'm advocating this, but just saying, if you want to tie yourself up and chuck yourself in the pool, it'll work, right? So you can have the non-medical specific stress inoculation testing, and that will transfer over. Now, I'm not really sure if you want to stand on top of a bloody building like that, freak, but that's the idea. You can stress yourselves out in other scenarios and learn how to deal with that stress. And one of the ways that you can overcome the fear and overcome the stress in any situation is by breathing. So we all know about the autonomic nervous system. It controls basically everything: sympathetics, parasympathetics, fight and flight, rest and digest, all that bullshit, right? The only real control that you have over your autonomic nervous system is your breathing. And funnily enough, if you actually take control of it, it alters the rest of what's going on. So for example, you know that ridiculous like sport where people like ski for ages and then stop and try and fucking shoot a target, like that's a good idea, like they're a James Bond villain or something, right? What they do, because you can imagine, you're skiing as fast as you can, it's pretty hard, it's a pretty big workout, and all of a sudden you've got to stop. And then like load a rifle using like fine motor control, and then try and somehow shoot at a moving target, like it's ridiculous. What do? They do this thing called tactical breathing. So I'll get everyone to do it now, just once, for the sake of getting used to it. You feel like an idiot, but it works. What you do, breathe in for 4 seconds, so count to 4 and breathe in. And then you hold it for 4 seconds at the top of your breath. Breathe out for 4 seconds. And then hold that for 4 seconds. You do that 4 times. So it takes a minute, not very hard. And I guarantee, already, you're probably all feeling a little bit less agitated. Because it works. It calms everything down. And that's a great way. People often, I'm not sure if you've ever heard it, people might say when you walk into these horrible situations, just take a breath. It's not that easy, right? Like take a breath, yeah, I'm ready to go. It's not how it works. When we say take a breath, what we mean is like calm your shit, get yourself together. And this is the way of doing it. What's 10 seconds in a resuscitation? Nothing, right? That's the time that it takes for people to work out what's going on, work out what your name is, not even. So take your time and practice it outside, because I guarantee You've listened to a lecture, you've tried it once now, you won't do it next time you're stressed. I promise you right now. But if you actively think about doing it, just do it during the day. Do it for a minute, every couple of hours. Just every time you remember, like, oh, I'll try that breathing for a minute. Then you'll start noticing that when you get into those scenarios, you will start trying it. And it will help. It'll help to calm you down. It'll help to let you think. It'll help move you out of that red zone, or the grey and black zone if you're all out there, down into the yellow or the blue zones. So that's fear. What about knowledge? So knowledge is pretty difficult, right? There's different models of knowledge acquisition. This was one, this guy, is it Richard Dreyfuss? No, something Dreyfuss, who cares? They might be brothers, Dreyfuss brothers, could be. They came up with this idea that essentially you transition through levels of knowledge. You start as a novice, and a novice is essentially what you will be next year when you're an intern. And the idea of being a novice is all you want to do is just not look dumb, right? That's all you're trying to do. Pick up a little bit as you go through, a bit of knowledge here, a bit of stuff there, and not look like an idiot. And that's about the novice level, and it's fine. Everyone goes through it with every single skill. Then you get to the stage of an advanced beginner. So you start becoming competent at a few things. You'll start learning to put IVs in, and you'll start getting good at it. You'll get better than the nurses on the ward who are bailing you out a few weeks before. You'll start remembering all the common antibiotics that your medical consultant starts to use, or you'll get really good at doing those discharge summaries or the coroners, which you actually have to do a fair bit. You get really good at doing very specific tasks, very little oversight. So no idea how those tasks generally fit into the whole, and you become very task-oriented very quickly, but you're efficient at doing it. Then you get to competence. Competency, unfortunately, is where most people stop, right? So competency is when you get there, you've got a good idea of what's going on, you can analyze information, synthesize it, put it together. You're not over the top of everything, but you're over enough. You've got enough control of what's going on. And that's probably where most registrars stop. They'll do an exam and get a bit more knowledge and then drop back into competency. It's where some consultants stop, because there's always someone else to bail you out, and people have a knack for not dying, so they sort of sort themselves out eventually. But if you keep going, you can move into proficiency. So proficiency is where you start to get really, really good. So you no longer have just an overarching idea of what's going on. You actually own everything that comes in. You know how everything fits in regarding the whole scenario. You get good at managing not just the patient, but the environment, the team, the hospital, everything else. And then of course, right up the top is expert. And they're like for any of you who listens to podcasts like the Scott Weingarts of the world. The guys and girls that essentially together own whatever specialty they're doing. The ones that are moving forward, that are taking it that next step, doing the things that no one else has thought of before. Now the thing is, has anyone done ALS? We've all done ALS here, haven't we? Yeah, cool. So that's really helpful when you're at junior stages, because what it does is it gives you a really nice way of using other people's expertise that they've synthesized down into a simple chart, a way of doing something, right? However, when you get to expert, has anyone here been in a resuscitation? Anyone seen someone die and then be tried to life? Yeah? Cool. The people that were running that resuscitation, were they like senior, like consultants? Did they follow A? Did you ever hear them say out loud specifically, all right, everyone stop A, airway, no, someone check, no, okay, B, breathing, breathe, sats. Or do they just get shit done? Stuff just sort of happen around them. And it's not necessarily in that order. They might actually be looking at C first. Oh my God, they would C before A. What the fuck? That's not the way the alphabet works, right? But it works, yeah? Because they don't need to do that. They reinvent the rules. In fact, for them, those sort of rules and those things that we learn are like restrictions, because they force you, those guidelines everyone bloody loves talking about. Oh, you'll start hating guidelines and policies. Sometimes helpful, but they're horrible because they're restricting. They don't help the expert. Now, what you want to try and do is move through and get to expert level. And unfortunately, I'm going to tell you right now, I don't care what you believe, whether you're an auditory learner or a visual learner. Oh, look at that, great. You have to read books, all right? There is no other way to learn than to read books. You can listen to me talk like this, and that's great because I'm giving you at the moment some sort of synthesized information. But everything that I'm telling you, I'm only telling you the sort of parts that I know I have to tell you, because everything else I already understand. But you might not. Have you had those people that are fucking geniuses that have no idea how to teach at all, right? Because they can't go back and work out in their heads what the steps were right at the start, because for them it's all natural, it's like breathing. So they don't have to do that. And the only way you can go through all those steps is to get a lot of knowledge, and the only way to get knowledge is to read. Sorry, whoops, I hate to be that guy. But you have to do it, okay? The other way that you can do it is by practicing your skills. So that statue down the bottom is of Sun Tzu. Everyone's heard of that guy, right? Art of War. So 500 BC, it was like this, wrote this book, it was all great. And he was basically a general who came up with these ideas and wrote them down, obviously, and it seemed to be very uncommon concept at the time. But one of the things that he talked about was skill, and he talked about knowing yourself and knowing your enemy. And that if you know yourself and your enemy, you'll never lose. So the idea is if you have control over everything you have, control over everything they have, you're going to win. If you only know yourself, which is unfortunately most people stop, then you'll win sometimes and you'll lose sometimes. And if you know neither, you're fine, right? So you have to acquire skills. And the skills don't just have to be about you and what you do and how you fit into the world, but about how that fits in for everyone else, for the rest of the resuscitation, for the rest of the staff. The other part, I put this slide up just because it's so ridiculous in how detailed it is. And so I like to sometimes, confuse myself and everyone else watching. It's about retological fallacies. What a boring fucking word. But anyway, it's just about all the things. How many of you have seen it or heard it before? Has someone ever walked in during I'm the surgical registrar and I think this person's abdomen's okay. Oh, fucking congratulations, well done. Yeah, do ya? Yeah, that's great. Yeah, what, because it says on your badge, the one that I'm happily wearing here now, right? Or surgical registrar. Does that make them any better at identifying a normal abdomen to anyone else? They're just hiding behind their badge, right? The registrar badge. I've done my exams. Cool, sure you have. Not a problem, you're still wrong, right? And there's a whole bunch of retological fallacies. And you'll go through and you will perpetrate all of them. I'm probably doing them right now if I went through and actually read them. But you will do it. And what you have to do is really understand that you're doing that. And you have to think about it. And the reason I say that is because right now it seems like I'm talking about ridiculous things. But if you're that surgical registrar that walks in, or you're the intern that walks in, and you think, it's fine, I've got this because I've been to med school, because I just had a lecture on med calls, because I've done my exams, you'll miss things. And that's how you then put yourself under stress. That's how you get worked up. That's how people die, right? So why don't we go on to decision making? So in an arrest, there are sort of four broad concepts. Unfortunately, you don't have information. So I've never, ever been to an arrest where someone has been standing there and as I walk in gives me a nice detailed, succinct history of this person and exactly all their medications and what's been happening in their bloods. It just doesn't happen. So in a situation, it's the same with met calls and the pages that you'll get overnight. You don't have complete information. And sometimes you can't wait to find the complete information. Unfortunately, it's an ever-changing environment, like rolling the dice. You actually don't know what's going to happen next. You could be doing the right thing and you still get a bad outcome. There's nothing you can really do about that, and you can't know. So often it's sometimes even hard to work out if what you've done is right. Because if it doesn't seem like it's right, then has it actually been the right thing? There are lots of variables. There are lots of things that can go on, lots of things that could have caused it. Could be the patient, could be medications, could be the nursing staff. There's no real way you can actually find that out immediately, but you have to be thinking of them. And on top of that, it's time sensitive. So you can't really leave someone dead for too long. You've got to do something and get them back. You can't have someone hypotensive for too long. People get a bit antsy when systolics get around 60 for a while, right? You've got to do something about it. And it's difficult. And the way that you approach that, through your decision making, there was this guy called Daniel Kahneman, and he actually was he's a psychologist, he's a Nobel laureate, one of those guys. And he came up with this idea back in the sort of 70s about decision making. He said, you know what, instead of actually like looking at sort of like rats in a maze and which way they go to like get which sort of cheese, he's going to look at people that are in intense scenarios, firefighters, military people, doctors, nurses, plane, like pilots. Look at how they react when things go wrong. So what do they do when they come up to a situation and the shit hits the fan? And funnily enough, he thought that it was going to be like a matter of, you know, a lot of experience, and you sort of come up to a scenario, you assess the scenario logically, and you come up with a list of potential plans and problems, and you calculate which one's going to. It doesn't actually work like that. The way it works is by gut feeling, right? And through that, he came up with these different systems, system 1 and system 2 of thinking. And system 1 is the rabbit. It's the fast, the gut feeling. So if I right now throw a ball at any of you, you'll catch it. No one ever sits there and thinks, what's the mass of the ball? I wonder if there's any resistance in the air right now because of the air conditioner. What loop do you throw? You just catch it, right? It happens naturally. You don't have to think about it. That's system 1. System 2, on the other hand, is when you're sitting down trying to actually work out the mathematical equation to describe how that ball flew through the air. You've got to sit down and work out. You can't just say, oh, I reckon it fell about right and this is how it went. You have to show you're working. That's system 2, right? Turns out that system 1 is probably better in most of the scenarios that you'll be in. System 1 also actually requires experience, so it sort of sucks, right? Because you're in like a catch-22. But what you try and do, and what we're trying to do through these lectures and through you continuing to go on and think about it, is to synthesize little bits of information and get better at having a gut feeling. And going with that gut feeling a little bit, and having someone watch you and see if you're doing the right thing. And that's how you progressively learn and progressively get better and make mistakes, like everyone does, and then get better again because you made mistakes. And then there's this guy, Hicks' law, and what he sort of came up with was the more decisions you have at any possible like point, decision-making point, the longer it's going to take to make those decisions. So if you've got 2 possible outcomes, it's pretty easy to decide. It's A or it's B, and that's it. If you've got 50 possible outcomes, it becomes really difficult to stack those up. And that's where that gut feeling of what's going to happen next, that you'll see people do over the next couple of years, and you'll start to do, starts to help. Now, there was another guy, unfortunately, he's another military guy. He's a pilot, and he was around when essentially planes were going through the phase and the military was going through the phase where they were all about technology. So faster technology, better weapons, smarter ships, all that sort of stuff, and that's what wins. And he came up with this idea. He had this concept. He said, actually, I don't think it's necessarily the fastest, most advanced plane that wins in a dogfight. I think it's the person that thinks the fastest. And he came up with this thing that he called the OODA loop. Observe, orient, decide, act. OODA. It's really simple. You come up to any situation, you observe. So you have a look, you take in as much information as you can, specific, consciously, subconsciously, whatever. You orient yourself to the scenario. So there's a difference between someone lying unconscious here versus in the middle of a fight, right? Same specific scenario, different orientation. You make a decision. The decision is some point of action, something you're going to do to perturb the system, to get your next bit of information or move yourself forward. And then you act, then you do it. And what do you do after you finish that? You go back and you do it again. You now observe and you orient and you decide and you act. And that's called the OODA loop. And basically he said whoever goes through that loop fastest ends up winning. And he had a standing challenge when he was in the military, for what it's worth, that he, throughout his career, said in 40 seconds, I can turn from being in the point of being in trouble with someone on my tail, about to shoot me out of the sky, to be in the position of power because he went through this loop faster. Do things, have a look, try, act, look in, work out where you are, try, do something. And throughout his whole career, he never lost a simulation, an actual dogfight, nothing, never lost. Now, the OODA loop has been made even more ridiculous with all these like crazy stars and feedback. And the idea is it's probably stuff that you actually do normally, right? Like you walk into a scenario, you take in information, you make a decision, you try and do something. What this forces you to do is to actively think about doing this over and over again. Observe, orient, decide, act. And I'd say that if you walk into any of your pages that you'll get, the MET calls, fast heart rate, low blood pressure, fast respiratory rate, hypoxia. If you walk in and actively think about this, if you do this quicker than anybody else, you'll get results. Things will change. You'll do well, right? So what you've got to just try and start doing is actively thinking about this, going into a scenario and not just trying to let it waft over you and get a feel for what's going on, pull it out the textbook and like, as much as that book sounds great, little handbook, reading through and trying to find the specific magic, so it's not going to be there, right? You've got to have a look at the scenario, get a gut feeling for what's going on, decide to try something and do it and see what happens. And then we get into the environment. So the environment is, there's sort of three broad things in the environment that you have to be able to control. You have to be able to resuscitate effectively. You have to be able to differentiate to work out what's going on. And one of the most important parts we don't talk about very much is you have to be able to communicate effectively. So we have to make everything easy. Very standardized. This is a photo of one of our MET call trolleys on the left. It makes it nice and easy because it actually goes down the list, A, B, C, D as well. So as you go from the top drawer, which is airway, you've got your immediate airway equipment. As you go to the next drawer, breathing, you've got things to assist you with breathing, whether it's the monitors, attachments to get your sats. You go into C and you've got drugs and you've got other things. So that's part of our resuscitation trolleys. And they're everywhere, exactly like that in the hospital. Why? Because then it's easy, right? You don't have to get into that scenario and try and work out, oh my God, wait, I'm on ward 7 North, this one, they've actually got their trolley, it's the other way around, it's already done, it's all the same. This is the sort of stuff, it feels like it's hard to learn, it feels like it's a pain in the ass, it feels like it's a waste of time to learn, but this is the sort of stuff that actually does help, because it buys you valuable time. It buys you a minute or 2 minutes, where instead of looking for something, instead of looking for that spot to get the IV, because you don't know where all the stuff is, you've got it and you can put it in and you're back on the OODA loop and you can go back through and start giving the medication. And all of a sudden, you're solving a problem and you're going through that OODA loop quicker than the pathology is going through the OODA loop and killing your patient, right? And of course, part of what, I've got a picture of Jordan there because of skills and training and about training the same way. So I have a real frustration, it really pisses me off, right? I'm not sure if any of you have seen central lines before. Does everyone know what a central line is, right? So it's a giant cannula that goes neck or subclavian or femoral, right? And effectively, those are lines that you put into people for extreme scenarios. You need vasopressors, you need to be able to give them fluid. It's not really a resuscitation line, but you need to put it in pretty quick sometimes. One of the things that really annoys me when I teach like residents or registrars to do these lines is they always pre-flush the central line with saline. And it really pisses me off. Because if you're in a real urgent scenario and you've got your boss there who's screaming at you, come on, get the central line in, come on, just do it, this person's dead, and you're struggling, you've got your ultrasound, you put this thing in, you get the wire, and you put your line in. Do you think you've had time to flush? No. So what's going to happen next? Normally, you flush your central lines. So the moment you get that line in your head, you're in the mode of lines in, I can use it, and you give medication through it. You're just giving someone a big evidence. So what I teach is to never pre-flush your central lines. Is it a little bit more dangerous? Yes, because it means you have to, every patient could potentially get near embolus if you're stupid enough to give something through it before you withdraw blood. But for the scenario where you don't have mental capacity, because your brain is being taken up by something else, your natural fallback is to withdraw blood from every single lumen first, because that's what you normally do, and then to flush them, and you won't stuff it up. And we don't train, or we shouldn't train, for the scenario where everything's okay, where everyone can relax. And that's not what you guys are worried about. You guys aren't coming here saying, for example, oh, I want to learn what to do when someone's heart rate's 90. No one cares. It's normal. It's fine. You've got all the time in the world to decide what you want to do, if it's normal or not. What you want to know is how to get through critical scenarios, critical episodes. And to do that, you have to have trained properly and have yourself in that right frame of mind when the heart rate is 90. So train exactly the way you're going to want to play in the critical scenario. The other thing is like stop points in a resuscitation. Has everyone seen these resuscitations that you've seen? Anyone ever seen like it goes to the shit pretty quick? It gets really loud, like noise just like starts, it's like someone turns on a speaker or something, and there's music and people talking and all this stuff going on. Have you ever had someone just like stop everything? Like just like everyone stop. One hides down. It's like a hard stop point where everyone can like gather together, get a brief like, all right, we're 10 minutes into this resuscitation. It's a continual PEA arrest. We've given adrenaline twice. We've got to get an airway in the next 5 minutes. And everyone stops and moves forward, right? So the thing that I do on MET calls, when I go to MET calls, because that's what we have to do unfortunately as ICU registrars, very first thing you do is you walk in, introduce yourself. You'd be surprised how many people don't do that. It fucking sucks. So walk in, introduce yourself, and then just say what's going on. Have a quick think about what's going on, and then give everyone a brief plan, even if your plan's fucking nothing, right? So let's take the fast heart rate. You've gotten a page, you're walking to the ward right now, and said heart rate is 140. We haven't called a MET call because we're in a hospital that doesn't have MET calls or something. Please come review, right? And you're walking over there, you walk in and people have started to lose their minds because the heart rate's outside the normal range, right? You introduce yourself. You say, oh, hi, I'm Jason, I'm the intern that's looking after Mrs. So-and-so. And he's like, oh my God, the heart rate's 140, and we're so worried, we don't know what's going on. You go, it's okay, everyone calm down. Why don't we spend for the next minute? We'll try and work out exactly how long she's been in here for, what medication she's on, and if there's anything that she's due for the moment. You haven't done anything, right? You've actually just told everyone exactly what you're going to do or what you're going to do anyway. And all of a sudden, people are like, oh, this person knows how they're doing, this is good. Yeah. And you feel more comfortable. How much more comfortable do you feel when someone comes in to any scenario, whether it's medical related or anything else, and looks like they have control, right? They tell you what's going on. And you're like, wow, this person knows. And you can have, instead of those hard stop points where you stop everything, you can have soft stop points. So one of the other things that we have to do commonly is transport patients. Now you can imagine transporting someone that's got bilateral EVDs and is intubated with a chest drain because of a high-speed MVA, which is why they're in as a 21-year-old. You don't really want to stuff that up. And there's a lot of shit that can go wrong. Tubes everywhere, things that can pull out, central lines that are in. It's a mess. And of course, inevitably, if there's anywhere that it's going to become a real mess, it's in the cramped elevator, right? When you've got no space and you can't move and something pops off. So you come up with these sort of soft rally points of like, well, if this happens, if something goes wrong and we actually lose the airway, why don't we, I'm not going to re-intubate them. Why don't we just take a laryngeal mask and we'll just use that to get us through the next few minutes, right? That's sort of the same thing that you do. So you walk up to that same patient, you've got the MET call 140, and you've walked up there, we're just going to find out her medications, we're just going to have a look and see what we get for the next few minutes, get a bit more of an idea of what happens. Someone says, I'm really worried about it. You say, that's fine. If her blood pressure drops below 90, I want you to tell me, and we'll give her some Metaramil. Right? And then you plan a little bit ahead as well. You haven't done much. You knew you were going to do that anyway. It's just you verbalized it and everyone knows about it. And these are other sorts of stop points. God, that came out really small. Yeah, it looked a lot bigger. Hopefully you guys know that. It's ALS2 algorithm, right? So, whoops. Effectively, it's nice and simple, isn't it? It broadcasts what it's going to do. It lets you know as you're going what it's going to do. And it's got two decisions. Are they shockable or are they non-shockable? That's the only decision you have to make, and it's really easy, right? Now, differentiation becomes hard. So this is where you have to sort of try and work out not just what's going on with the patient, but what's going on with the rest of the team dynamics as well. So you as the intern are the brain of this whole fucking mess. And it will be a mess. You'll walk in and there are patients and relatives and nurses and other doctors that are not there from the team, but that got there first, that have no idea what they're doing. And there's a cleaner in the room and there's a computer in the room as well. It's a pain in the ass. And your job is to work out the whole scenario, work out the whole of the environment, get it all ready as you want, and to organize it. Now, as the brain, you don't have to do the cannula. You don't have to get the medication. You don't have to get the relatives out of the room. You just have to direct people to do it. And so one of the things you'll have to get good at doing very early on, which is really difficult because it requires, remember that Dreyfus pyramid? You're at the novice stage of like, I just don't want to look like a fucking tard. And instead, what you have to do is actually quickly ascend a couple, like fake it till you make it, but pretend you actually know what you're talking about and be like, can I just get you to please do an IV? Can I get you to get some medications? Can you get me the history, right? And you start organizing the room a little bit, using the assets that you've got. It's really difficult. And it's even worse when you're under stress. You'll forget to do it because you just want to be doing something, because doing something seems to help us, right? Which is why you have to go back and start breathing. So it all sort of links in a little bit. And then we go to communication. So how many times have we seen communication? How many times have we been told, don't just yell things to the room? I need an IV! Who gets it, everyone? Right? And yeah, it seems simple, and it happens all the time. So you have to be really direct. So I don't know any of your names, unfortunately. I apologize. I didn't look at them before and learn. But if I wanted to talk to any one of you, I can make specific eye contact, I can point at you, and you know exactly who I'm talking to right now. So if I now say, I need you to go and get me an IV, you'll know that I need you to get me an IV. And no one else in the room will know. Everyone else knows that you're the one that has to do it, not them, you, right? So that's how you can very effectively, no one likes pointing, but unfortunately it works, right? You can very effectively communicate by being extremely directive. You can take those little timeouts like we have to. So when people start doing shit and you're like, no, this isn't where we're supposed to go, you can get everyone to calm down for a second. Oh, everyone just calm down, it's okay. Can we just go back? We were supposed to get an IV. Did you end up getting that IV or not? Because you're still sitting there, I don't think you did. No, right? Or you can say, where's that med chart that we were looking for? Did you end up getting that med chart? You want to have a look. And you can sort of stop everyone a little bit, right? And what it does require is for you to be a little bit flexible as well. So you have to understand that what you see as priorities might not actually be the immediate possibilities. It might not be the way that you will get things. So often, it's really important that people have a blood pressure that gives them enough blood to perfuse their brain. However, often the metaraminol is very far away. And so it's difficult to get to despite the fact that it's the priority, it's the number one thing you have to be doing right now. So what you have to do is get good at having that list of things that you want done in your head and understanding that you want those things done, but also accepting that in reality, you just might not be able to get them done in the order that you want. And we go back to put that slide back into the methodological fallacies for the sake of remembering as you go through why you're asking for things. And then we get to the end of the resuscitation, the end of the MET call. The heart rate is finally dipped below that magic 120 and it's no longer your problem, right? Now it's just the next obs in 4 hours. So Napoleon said that the moment of greatest vulnerability is immediately after you won. Because that's the time when everybody calms down. You've achieved your goal, right? Have you seen in those resuscitations, for those of you that saw them, if that person got back, the moment you look at that next defib rhythm check and that comes back as a perfusing rhythm and someone checks like, oh, I've got ROSC, everyone's like, oh, whew, all right, I'm out. See, and I like sort of stop doing stuff. It's the same person with dead seconds before. Everyone's like, well, that was good. So coffee, it's time to go. Yeah, well, it's late. I missed our break. How about that, right? Because you've sort of achieved your goal. So what you have to do and what you'll learn to get good at is once you've achieved that goal, actually setting up the post-resuscitation care, the post-MET call care, all right? And there's a little acronym. So the SWAT teams is an acronym that's similar called LACE, like liquids, ammunition, something, I don't know, some bullshit, right? The idea is that it's some acronym you can use to quickly in your head go through what are the things that I have to organize before I get out of here, right? So the team, you have to tell the team what's going on. And that team isn't necessarily the home team, because you might be the home team. You're the intern that just responds to the bloody MetCall page, right? So you are the team. But that means the nurses around, the patient as part of that team. So we'll talk about them specifically in a second. The family, you have to let them all know, okay, we've just had that MetCall. She was in rapid AF, but it was actually because no one had given her a beta blocker. We gave it to her and it's calmed down a little bit. So we'll watch her for the next half an hour. If her heart rate goes up, let me know again and I'll come back and reassess. So for the next little bit, do more frequent obs. After that, go back to 4 hours, right? So you sort of give them a little bit of what's going on and what you expect to happen from here. You have to reset the area. It's not as much of an issue really on the ward, because often the resetting the area is not our problem. So it's just sort of like, you know, drop the cannula, I'm out of here. But in a scenario where you own the resuscitation space, like me in ICU, you have to reset everything, because for all you know, there could be another one that's about to come in. And if you take the time then to sit down and have a break, the patient is key in a lot of things that you will do. And you'll look really good as interns if you've got good rapport with the patients, because most registrars and consultants don't. The consultants like to think they do, because they walk in a jacket and they sometimes like hold a hand of a patient or something and tell them something in medical jargon, and everyone's like, oh, yeah. No one understands, right? If you walk in as the intern, mother of this 21-year-old girl that's admitted with DKA actually says, oh, hey, Chase, I can't believe, yeah, that was really great. Thanks last night. Everyone's like, oh, what was that? That's pretty good. Obviously done well, right? And involving the patient, because it is all about patient-centered care, is really key to all of these scenarios that you're going to face. So tell them what's happened. And I often tell them during, even in critical scenarios, even as they're fatally bleeding out, even as they're losing consciousness, even as we're about to take over the airway, you tell them what's happened. I had a horrible, oh my God, like anus clenching disaster the other morning, 6 o'clock, because it's always when it happens, right? 6 o'clock in the morning after a night shift. Just come upstairs with a young 33-year-old that's had subarachnoid hemorrhage into both ventricles, GCS3, intubated. We're rushing her over to neurosurge. She's come through the scan, so neurosurge are on their way into putting bilateral evidence. So it's already a bit of a stressful scenario, right? And as we walk in back into ICU, because overnight you're always understaffed, get ready for it, right? So understaffed, back into ICU, and someone says, do you mind coming and checking out this patient over here? She's just become a little bit bradycardic. I'm like, oh, fine, whatever. It's not my pod. Someone else's problem, you know, like another registrar, but I'll go and help because they're obviously not here. We walk in, this patient's got a heart rate of 20 and a blood pressure of 50 systolic on an intra-arterial line. It's a young 24-year-old girl, right, that's had a motor vehicle accident a week before, is now a high spinal, and is having autonomic dysreflexia. You know, standing there watching.
Oh, it's normal. No, when you chest physio, it's normal. She gets a bit low, the heart rate.
Yeah. Of course, it's a bit of a like, ooh, what are we doing, right? But that's not even it. That's not even the worst part. So we give her a bit of atropine. Like heart rate comes up. Luckily, she becomes conscious enough that we can start talking to her and say, hey, honey, yeah, you just passed out because your heart rate and blood pressure were really low. Yeah, it's okay. Everything's fine now, not a problem. She's got a tracheostomy, right? So she can't talk. So we leave because we got the neurosurgical disaster that's waiting to happen. We're trying to rush off to theatre. And as we're standing outside, we hear another call for help in there. We go back in. The nurse has a bag and is trying to ventilate through the tracheostomy because her SATs have now dropped to 70. Her face is swelling. Like, shit, you're not out here somewhere. Couldn't see her eyes, couldn't see lips or mouth. All gone, chest is swelling. Tracheostomy had been dislodged. At some point during that previous resuscitation, we lost the tracheostomy. And now we were ventilating through. Whoops. So we filled up basically all of her subcutaneous tissue with air. It's not a great idea. Turns out you can't exchange oxygen between your external chest cavity and internal. And we've now got a trachea that doesn't work in a 24-year-old who now has severe airway subcutaneous emphysema So it's turned into effectively a grade 3 from the top if you want to try and do anything. And we can't even do front of the neck access because she's got front of the neck access, lower down than our emergency access, right? And through all of that, despite this horrible clusterfuck of a scenario at 6 o'clock in the morning, the patient was actually still awake and conversing, trying to just squeeze it rapidly because she was shit scared, because she could feel that her face was blowing up, right? And that didn't make it any easier, as you can imagine. It's pretty tough to deal with that when you're standing there actively thinking in your head, I've got a 24-year-old that I might actually have just been involved in killing. And she's awake, right? She's still there. You doing okay? She gives like a thumbs up or a thumbs down, like actively with it. But talking to her, taking the time through that scenario to talk to her, I shit you not, helped everything else. Because that's got low. We took out the trachea, we ventilated her from the top, her blood pressure dipped, so we gave her medication, then we intubated her. But before all of that, we talked to her the whole way through. I had one of the nurses standing by her, and I would intermittently, because I was standing by the side of the bed trying to lead it, because we were people down, so I had to be doing things as well, unfortunately. And we talked to her, and it made everything quieter and calmer in this horrible scenario. So please remember, of everything I've taught you about managing your own fears, about mastering expertise and decision making, remember at the end of the day that there is a person lying there in front of you. And for as much as you sometimes do not give a shit at that time of the morning about some stupid number, there's still a person there, so talk to them. And it helps a lot. It's a really long-winded way of getting around that. But talk to the patient, right? And the last thing you have to do when you leave the room is the equipment. That's the boring part. Sort of part of the area. I just put it in there because TAP sounded like a bad acronym, so I put it in there as well. Now this is the thing that I have to say, obviously, that I hope you never have to do, but you will. Let's be honest. If you end up doing anything that's critical care in nature, you'll be a part of resuscitations, and you'll be part of resuscitations that go bad. And though you might not be the one leading the resuscitation, you have to be involved in the decision-making process about stopping the resuscitation. I'll only take a second to talk about it, so I don't think it's necessarily something that you have to be aware of. Other than the fact that when it happens, everyone in the room knows it's happening. So you can take that sort of mental pressure off, that it's not you that's doing anything, it's not you that's stopping it, it's not you that's killing someone. You know, they're dying, and you're allowing it to happen, and that's fine, because it's nature, right? And there are ways of communicating that with the room. So I'm not sure if you've ever seen someone handle it poorly. Have you ever seen someone walk into a resus and be like, I could not believe we're doing compression on this 87-year-old, just stop right now. That's horrible, right? That's disgusting. However, if you walk in and you say, I know this person's, continue what we're doing, I know this person's got a resuscitation form that says she's still for full resus. We've been going now for 15 minutes. She's got no end-tidal CO2. We haven't had a shock rhythm for a while. It looks like we might have run out of options. Does anyone have any objections if we go for another round or two and see what happens? Same thing, same outcome, right? But at least this way, everyone feels like they've got a chance to be involved. Everyone's got a chance to say, actually, we haven't tried sodium bicarb. Someone always wants to use sodium bicarb. I don't know why. Don't be that person, please. Haven't tried sodium bicarb. Yeah, all right, give it a go. Yeah, didn't work. I don't know who would have thought. All right, sure, right? And that's the way you can try and manage those scenarios. And I tell you that because I think though we talk a lot about things that we do really well, we treat very aggressively, I think we don't do very well, like the final stage. Like everyone has to go through it, everyone's gonna die, right? And we torture people because we do it poorly. So I can't really sit here and give you a resuscitation talk and not talk about what happens at the other end when you have to stop the resuscitation, because that's one of the outcomes, okay? And unfortunately, that's a pretty shitty way to finish the talk, isn't it? Because here I'm trying to talk about all the good things, mastering your fears, mastering your knowledge, the decision making, the environment. And I've ended it with, so when you have to kill, let someone die, it sucks, right? But these are the sort of things that, these sort of ups and downs, you'll go through. And it will happen. I promise you, next year, you'll feel up and down and up and down all the time over little things. You'll find things all of a sudden get you like feeling really awkward or emotional that you never even knew existed, right? It'll be something that triggers you for no reason whatsoever, because you're going to move into an environment that's pretty emotionally charged. And so you really have to be able to take control of everything. And it's not just for the resuscitation. It's for outside the resuscitation. The tax stuff, all that crap. Take control of it, because you're going to need to. You're going to need to de-stress yourself in every way, because you'll find that's going to be the thing that actually helps you survive through internship, whether you can manage and cope with all of the extra stresses around. Any questions? All right. Okay. So we've got a bit of time. If anyone wants to ask anything, open mic night, by all means, go for it. Otherwise, let Michael know about what we were talking about before regarding the sort of antibiotics, analgesics and stuff. Like I said, if you really feel like you want me to go through Ceftriaxone's 1 gram daily, I'm happy to do it for you. It's about what you guys need. But if you want, we can go through actual more medical scenarios, how to respond to things. We'll do a lecture on fluids. We'll do a lecture on, and there's another lecture set to do like sort of tachycardia, arrhythmias, hypotension, how to get cool. But that was just a bit of a primer to at least get you all set up for how to deal with it. Any questions at all?
Well, thanks, Jason. And next week is fluids.
Yeah, next week we'll go through fluids. And probably maybe a bit of sort of net calls relating to whatever. We'll work it out. Cool. No problem.